Good morning and welcome to the Manx Care Board meeting. I have received apologies from Kate Lancaster, one of our non-execs, and also from Jackie Lawless, but Ash is here to represent Jackie, so thank you for doing that. Are there any other declarations of interest that are not recorded on our register and are pertinent to today's business? No. Thank you. So we have the minutes of the meeting, last meeting that we held in public on the 5th of September. And I will just ask, as I go through them page by page, for any points of accuracy. So page 1, page 2, page 3, 4, 5, page 6, 7, 8, page 9, 10, and then we go into the questions from the public up to page 15. Any issues of accuracy? No. So thank you, Elaine and Jane. We can accept those as an accurate recording of that meeting. And then if we go to the action log, so there are 4 items on the action log. Oliver to speak to the Cancer Services team about proactively collecting qualitative data. It was completed and reported to QSE.
Yep.
Brilliant. We can close that one then. The Manx Care record escalated to the board. We had a discussion about that yesterday, Katie. I think that remains a serious concern.
It does, although there was a sort of a hint of it moving forward from the Minister yesterday. I haven't had anything substantive, so we'll talk about that next week at D&I.
So you've got your committee meeting next
yes.
week. Excellent.
Yes.
Okay, so we can bring back a report to the next meeting then. A quarterly update on progress with the CQC action plan to be brought to the board. That's taken through QSE.
Indeed it is. It's in progress, Chair. We have regular reporting through the CQC and we intend to bring it through the board every quarter.
Thank you. Dental provision to be raised at the mandate assurance meeting.
That hasn't happened yet, but the next quarterly mandate assurance meeting is on the agenda.
Okay, so we just need to update the action log to say that that's going to be discussed at the next mandate assurance meeting, and then perhaps an update can come back to the board on that. Notification of any other items of business that are not on our agenda that you'd like us to cover at the end of the meeting? Nope. Thank you. So welcome to Ian Wright. Thank you for joining us. Does anybody want to introduce this item? Or should we go straight to... Do you want to say anything, Teresa?
No, I don't think so. I think we're very happy for Ian just to share some really positive news.
Excellent.
So I'm here to talk about the hip fracture database because in the recent report published a couple of months ago, we've done quite well on some indicators, and particularly Key Performance Indicator 2, where we came top of the whole British Isles for access to surgery. I thought I'd give a bit of background, if I may. Hip fracture database was set up by the Royal College of Physicians in 2007. I think here we joined pretty much at its inception, and if I recall correctly, it was Tracy Hall, who was the then sister on the orthopaedic ward, who, together with me, all those years ago, signed us up, and we've been inputting data ever since. It monitors performance across hip fracture care, and since it was set up in 2007, because of the initiatives and the research based on the data submitted to it, there's been a nationwide 50% reduction in 30-day mortality after hip fractures. In the olden days, when I was a junior trainee, hip fractures was seen as a pre-terminal event, generally speaking, with a mortality of approximately 50% after 6 months. So it was an end-of-life event we've improved the care of those patients since, thanks in part to the hip fracture database. In recent years, in the UK, where they have payment by results, they've introduced the national tariff for hip fractures. And if you manage to hit all the key performance indicators per patient, you get an enhancement of that tariff, a best practice tariff. So it encourages the trusts in the UK to do hip fracture care better on a continuous basis. We've always done quite well with the prompt surgery indicator. We don't have the capacity problems that they have in, for example, Aintree. You hear stories that they've got 18 hip fracture patients waiting to be done. We get about 100 a year. I think it was 80 when I started. It's now over 100, so numbers are going up. So that's 2 or 3 a week, generally speaking. And the key performance indicator 2 is surgery within 36 hours. Our median is currently running at 18 hours for surgery. I did 2 over the weekend. There was one patient came in, I think the small hours of Friday morning, and he was in theatre by 9 o'clock on Friday, done and dusted. Another one came in on Saturday afternoon, and we were in theatre Sunday morning. So we're hitting that target pretty well, and on the database we get 91% of our patients taken to theatre within 36 hours. The other 9% is generally there's a medical reason for not doing it. It's not that we don't have the capacity, it's that they needed to reverse anticoagulation or something like that. So good performance there. We've got other areas of good performance. Key performance indicator 4, mobilisation. That's thanks to our physiotherapy service. We're doing that 7 days a week, so the on-call physio at the weekend will make sure that the patients with fractured neck or femur, day after surgery, get out of bed. And we've got a 98.2% success for that, which only puts us 9th in the league table. But you're not going to much improve on 98.2, I don't think. We're doing very well at getting patients home, and our own figures, which aren't part of the database, our time to discharge is much quicker than the UK as well. We've got a median acute stay of, I think it's 8 days, whereas in the UK it's 10. And 83% of our patients are going back to their usual residence. Areas for improvement, all the medical stuff. For years I've been saying that all we need is an orthogeriatrician. For long before most of you guys around this board table were involved in Nobles Hospital, I've been asking for an orthogeriatrician. We've had various attempts over the years, and various physicians have done it a bit, but this year, finally, we've got Andy Davis in post, who is transforming our service on the other side of it with the general medical assessments, delirium, bone protection, the other sort of things that orthopaedic surgeons, well, you know what orthopaedic surgeons are, we fix the bone and that's it, we're done. Whereas the physicians will look after the holistic care of the patients, and that's transforming what we're doing, such that next year I'm hoping that we'll be up towards the top on all of the 8 key performance indicators. But we will see. Happy to take any questions if anybody wants to ask anything specifically.
Thank you. Thanks very much.
Cool.
Thank you. I just want to say, just to acknowledge what an achievement this is. This is the first time in my whole career I belong to an organisation that's at the very top of a chart like that. So it's wonderful. Pay tribute to you and to your team. I know it's a team effort in getting these kind of results. I wanted to ask about whether you might say any more about, with performance as strong as this, is there any tangible benefit that we see playing out in mortality indicators or people returning to functional status sooner, on say like a patient reported outcome measure? Is there any data that might suggest that this excellent performance leads to real benefit for people?
Well, I've already mentioned the figure of return to patient's own home. That's see, it used to be said that after a hip fracture, everybody goes down one level of mobility or one level of independence.
Yeah.
But we're not seeing that now. So I think the rapid surgery is the key to this. Every 24 hours they spend in bed waiting, function decreases. Patients with a hip fracture, the fittest they can be is the moment they hit the floor, and from that time on, their status is declining. So rapid surgery, that's the first part of the journey, which will facilitate the rest of it, facilitates them getting up and about with the physio quickly, which facilitates recuperation, getting back home as soon as possible.
That's great, thank you.
Charlie.
Thank you, and again, congratulations on that performance. I'm just intrigued to know what you're needing to perform is essentially unplanned surgery.
Yeah.
Isn't it? And I'm just impressed with the way over weekends you're able to coalesce and rally that team for that unplanned surgery. Be interesting to have some insights into how you make that happen, and if any of those lessons could be transported through to other areas of unplanned surgery, if there are difficulties in them coalescing their teams in order to undertake that operation. It's just very impressive that you're able to get that team around that patient so quickly in surgery.
It's been a bit of a battle over the years. We didn't used to have access to a trauma list on a Monday. That was another battle we had many years ago, where we had to insist that there was a dedicated trauma list on a Monday. So we've got trauma lists every weekday now where we have access. So we know that we can get to theatre the next morning, generally. At weekends, yes, you are in competition with the other teams. In orthopaedics, what we tend to do is turn up early. It's almost a bit like a first come, first served. Obviously, if one of the other specialties comes in and they've got a really sick patient that needs to take priority, we have that discussion. But generally speaking, 8 o'clock in the morning, Saturday and Sunday, if we've got any cases, they're booked in theatre, we'll be round in theatre, we'll be knocking on the door of the anaesthetist saying, let's go. And that's what we do.
Fantastic practice. Yeah, it'd be good to share that practice of how you actually make that happen.
Yeah. Orthopaedics has always prioritised trauma. If we had a choice, you know, elective patients, well, it's unfortunate they can come back another day, whereas your trauma patients need getting done.
And I think the point you made about the deterioration, you know, in each 24-hour period, that's clearly absolutely the right thing to do.
That's well established from the database figures that your mortality just goes up and up the longer patients are waiting.
Yeah. Nigel?
Yeah, thanks, Sarah. Through you. Ian, thank you so much for that report and that sort of tour de l'horizon of what's going on in this area. It's so good and heartening to hear a good news story. As you can imagine, we spend a lot of time around this table dealing with bad news stories and dealing with tension, and it's so good. And I repeat and echo all the thoughts to you and your team about this, and thank you for that. I'm being a bit opportunistic having a senior orthopaedic surgeon here, but I'd like to ask you, we've been successful in gaining funding and quite a lot of money from government for restoration and recovery to play catch up after COVID on orthopaedics and joint replacements and hip replacements and things. And we've obviously used an external company to do that at Synaptic. I'd just like to get your take on the sort of wind down from that and how that sort of relationship has gone and how it's working in terms of getting back to business as usual, having played a degree of catch-up, and what's your take on that at the moment, please?
Well, the Synaptic project was important to get us started again. Going back, if my memory serves me correctly, we paused elective surgery, I think, for basically no staff, not physical bed space, but no staff to run the ward in something like October 2021. And the Synaptic project started, I think it was April last year. And initially that was using us as the orthopaedic surgeons, but we were shipped in an anaesthetist and a ward team and a theatre team and a physio, and that started the restoration project in joint replacements. And since then, we've expanded capacity by working alongside the synaptic surgeons as well, and getting through the joint replacements. We've pretty much completed that now, and recently, I'm not sure if it's fair to say, but synaptic have sort of been scratching around for work to do. There's not many straightforward joint replacements, which is what they've largely concentrated on. We've been doing the more sort of challenging cases, I suppose. And on paper, it looks like, well, synaptic have done lots, and the local orthopaedic surgeons have not done much. But the way it's worked out, we've had less access to theatres than the visiting team. But I think it's run its course now, certainly in terms of surgery. Waiting times for orthopaedics across the border, what I would consider to be reasonable.
Yeah.
We've used the knowledge that Synaptic brought us. They didn't bring us any surgical knowledge. We haven't done any operations differently, but in terms of length of stay and the enhanced recovery, it wasn't that we didn't know how to do it, it was just that nobody did it because it was outside their comfort zone. When I started, again, years and years ago in orthopaedics, the length of stay for a joint replacement was 2 weeks. Before Synaptic came here, my personal length of stay was either 3 days or 6 days. So I operated on a Tuesday. If I went home on the Friday, great. If not, they'd stay until the Monday. And the Synaptic team that came in with the whole sort of package on the ward with the physio, the advanced nurse practitioner, and they were brutal. They'd just get the patients up and say, right, you're going. Such that our median length of stay is literally 1 day. You know, patients go in 1 or 2 days. And we're hoping to carry that on. We've recruited one of the Synaptic people to work with us, James Duff. I think he spoke at this meeting before.
He spoke to the board,
And he is working with our own staff on Ward 12 to carry that on. And Ward 12 currently is staffed by our own staff rather than Synaptic people, at least during the day. I did 2 joint replacements last week on Wednesday. They both went home on the Friday. And these weren't straightforward sort of fit. Well, I've done 1 or 2 that have actually gone as a day case, which is remarkable.
Wow.
Amazing.
Compared with how it was years ago. But next day delivery has been pretty much the standard for joint replacement over the last 18 months or so.
Great.
Really interesting. Thank you very much.
Thank you. Teresa.
I mean, it's obvious, but I think it's an important point to say is that we have to make sure that all the parameters which allow this excellent performance to be achieved, we must protect and lock in. You know, and it goes without saying, doesn't it? But that access to that daily trauma list, the way the weekend rotas are structured, in the fact that we have physios at weekend, all of these things that we must make sure and understand these are the things which allow this performance to happen. And we must make sure they are protected and locked in, so we can then continue to secure that good performance and then build upon it as we, you know, hopefully with Andy Davis and another geriatrician on the way, we can continue to sort of achieve that really good performance. But
with joint replacements, it's particularly sensitive to ward occupancy. If you get a medical patient on the ward, joint replacements stop. Because of infection control. We're doing it in a clean unit. All the patients that come through have been swabbed to make sure they're not carrying anything. We can't have a medical patient in the next bay that's on antibiotics for a chest infection, for example. So ring fencing of elective orthopaedic beds, if you want to maintain throughput of joint replacements, is essential. So otherwise we stop.
Yeah. And that's another further really important point that we have to make sure that we're managing flow and that wider piece, that we've sort of making sure that's understood.
Any other comments or questions? Well, thank you very much, Ian, for coming to talk to us, and you know, many congratulations. And it's just, it always strikes me when you talk about, you know, the length of stay when you first started and now, and you know, the impact that has on the individual is extraordinary, isn't it? That you can come in extremis and you can be
put back together and sent back out within 48 hours rather than, as you said, kind of two weeks or longer. So thank you so much. It's really good to hear. Thank you.
Okay. I better get on to French
Well
clinic.
Thank you. So, Oliver, I think we're coming to you for the BAF this morning.
Yeah. So we're doing the deep dive into BAF risk 2, which is overwhelming demand. I presented this about 6 months ago, I think. Since the previous deep dive, the risk has been upgraded to 15, which is likelihood of 5 and impact of 3, to recognise the increasing frequency of extreme pressure being experienced across the entire health and care system. So whilst Nobles has had the Opal score in place for a couple of years now, so we are able to track that rating on a day-by-day or week-by-week basis. Similar pressures are being felt across the system, whether that's primary care, community, ambulance service or social care. And in particular, we have seen this year an unseasonable rise in unplanned demand across all of our system, with ED attendance in July of this year being the busiest month on record. So we're not alone with seeing this rise in demand, with ambulance services in the UK seeing record levels of demand also in July 2023. And as we move into the winter period, this is only going to increase as people close windows, move inside, and the risk of transmission of respiratory and other illnesses increases. Also, as we move into the second year of the cost of living crisis, the most vulnerable in our society will yet again need to choose between heating their home and eating healthily, with either sacrifice likely to result in the need to access health or care services. So the BAF risk covers 5 main points. The first in relation to COVID-related demand. So although the island has been adopting the endemic approach since April 2022, we do continue to see transient increases and decreases of COVID-19, which both from a patient and also from a staffing point of view does prove challenging to Manx care. We continue to operate the COVID vaccination programme and are currently delivering the autumn booster programme, which has been running for just over a month now, and we've delivered as of 22nd of October 6,983 booster vaccines, with clinics booked every day both within the Chester Street Vaccine Hub and also more on a locality basis, as well as delivering COVID vaccines in nursing homes and also to the housebound. The COVID escalation plan remains an active document within Nobles, and has been activated as most recent as early October, when there were over 10 inpatients with COVID-19 in the hospital at any one time, which meant that we had to convert one of our wards into a cohort ward to reduce the risk of hospital-acquired or hospital-transmitted COVID infection. The escalation plan was only activated for 15 days, after which time we were able to de-escalate the situation. But clearly our policies still in place around mandatory isolation for staff, or not isolation, mandatory staying away from work essentially for a minimum of 5 days, which when that happens does have a tendency to cause quite significant staffing issues, particularly within the hospital but across the whole sector. The second risk is around escalation planning. As I mentioned earlier, we've had the Opal framework in place for a couple of years now within the hospital to reflect our operating pressure. As mentioned earlier, we have experienced a higher frequency of Opal 4 days, particularly in August, September and October of this year. However, in each of those days, targeted action across the system, not just within the hospital, but across the entire system, has meant we've been able to de-escalate from Opal 4 to Opal 3 in a kind of 12 to 16 hour period. However, we did have an instance earlier on this month, earlier in October, where we were operating at Opal 4 for more than 24 hours, and that was the first time we've ever had that, due to a combination of factors, but principally demand coming through the front door through ED. The Opal framework is currently under review to look at taking into account staffing pressures, because it only calculates the Opal score based on flow, principally demand and capacity. But as we know, the impact of staffing has a huge effect on flow. And we are going to start looking at a community Opal system, which takes into account pressure within primary care, community services, district nursing, community therapies, etc. Community Opal frameworks are now commonplace across integrated care systems, so that integrated care systems are able to track the pressure across their entire system, both the acute providers, community, primary care, ambulance service, etc. And I'm going to start that piece of work shortly in conjunction with our community partners, primary care network, etc. The next is around service transformation of urgent and emergency care. So the Sir Jonathan Michael report, which came out in April 2019, indicated a lack of integration across various urgent care services delivered by the then DHSC. We've been working on that recommendation for some time. Well, I certainly have, having come from the DHSC, however, the progress of that has been somewhat limited due to the pause of the Care Pathways transformation programme, which has been on pause for almost 12 months now. We did make a decision earlier on early in 2022, that despite the pause, we would continue as an organisation to push forward the various urgent and emergency care transformation projects. These are Hear and Treat, intermediate care, See, Treat and Leave, and same day emergency care. And I'm glad to say that all four have received healthcare transformation funds, so that they can all be funded for the first 2 years of their existence, which is great news. Hear and Treat has been the first to be launched and is currently in a phased implementation since June 2023. September data has shown that 259 calls have been clinically triaged, with 114 either being downgraded or upgraded, and the remainder being redirected to an alternative pathway. The alternative pathway figure will increase as more and more alternative pathways come online, such as intermediate care, crisis response, and See, Treat and Leave. The See, Treat and Leave service is in relatively early stage. However, we have recruited the island's first consultant paramedic, who will take forward that service from an advanced practice point of view, and will build that service, which will be comprised of advanced nurse practitioners and advanced paramedic practitioners. Similarly, the same day emergency care project is relatively new, with recruitment of key practitioners underway, and we are currently looking for a venue for that service. I guess one of the most advanced is intermediate care, thanks to the fact that intermediate care primarily builds on an existing service, which is reablement, and essentially increases both into the number of staff within that service and also the range of clinical skills. So we're currently recruiting into that service for additional review and assessment officers, referral and assessment officers, additional reablement support workers, and also the service's first specialist physiotherapist and also its first social worker. This will mean that the reablement team is able to increase its ability to respond. So it will move from the reablement and assessment service will move from 4 days a week to 7 days a week, and the response time can be as little as 2 hours, depending on the need. And we're just also in the process of recruiting 3 advanced clinical practitioners into the intermediate care service, and those are based on our advanced practice framework, and they will primarily undertake the initial assessments for people who are referred into the service by other clinicians, as well as support their step up, step down programme or pathway through Martin Ward. The fourth risk is around demand and capacity planning. This has been a piece of work that's been underway for some time to help build the Recovery and Restoration Phase 3 project. Mr. Wright talked about Phase 2, which has reduced significantly the orthopaedic waiting list, amongst others. The Phase 3 business case will be focusing primarily on outpatients, cross nobles, as well as mental health. And in order to produce that business case, we've had to do demand and capacity planning across all of those groups, all those specialties. But that data will also be used as part of the key core service planning tools that care groups will be using for planning their demand and capacity for next year, which is essentially the first time we've ever had that data. We're also going to start a piece of work around developing a 5 to 10 year forecast of unplanned demand for Manx care. This will enable us to accurately forecast essentially all of our unplanned services, whether that's ED, the size of do we need a bigger hospital? Do we need to increase intermediate care over the course of the next 10 years? Community nursing, primary care, etc. And that's both linked to physical as well as human resources. And they will obviously link into the island plan too, because that clearly one of the objectives of the island plan is to grow the population, and more people means more health services, more demand on the health service, and therefore we need to expand accordingly. And the final point is around winter planning. As I mentioned earlier, winter is one of the highest periods of pressure for the health and care service. So people suffering winter illnesses, as I mentioned before, as people move inside, as well as increased falls and exacerbations of symptoms of frailty. Last year we had our first winter plan, which was a success and noted as within the DHSC's assessment of Manx care as one of our successes in the year. We have had some update regarding this year's winter planning budget, in terms of we've since gained clarity on what funding is going to be available. So I've asked all key stakeholders to provide me with their requirements for the winter plan. That will be primarily additional clinical staff across primary care, community and the hospital to help us deal with the additional demand, but also principally looking at whether we are able to offer services on the same 7-day period. So making sure that the level of staffing within the hospital, whether that's physiotherapy, occupational therapy, clinical pharmacy, social work, equipment, etc., is the same on a Sunday as it is on a Tuesday, meaning that we maintain the same level of discharges throughout the week. And that's it. Thank you.
Thank you. Any questions or comments for Oliver? Katie?
Oliver, could you just remind me, please, on the COVID vaccination, which categories of patient are still being vaccinated? Because in the UK, they've obviously now stopped doing the over 50s and what have you. Can you remind me where we are here?
We follow the same as the UK.
Okay.
So over 60s, or is it over 60s or over 65s, and clinically vulnerable. The JCVI are constantly reviewing that,
Yeah.
with a view to potentially matching the same eligibility as last year, which is 50 plus. And obviously, if they make that decision, then we do have enough operational resilience to be able to respond to that.
Okay, thank you.
David, then Charlie, then Teresa.
Thanks, Oliver. Oliver, I'm pleased to hear the intention to develop a community Opal rating. Can I just confirm that social care will be a part of that as well? It's just it wasn't in your list of...
Oh,
things
yeah,
that you're looking at.
it will be.
I thought it would be.
Yes, it will be, yeah. As I said, I went to a conference a few weeks ago which had a really good presentation from the chief exec of one of the ICBs in the UK who demonstrated a new artificial intelligence tool that they've got to model demand and capacity across the system, and you can essentially kind of change metrics within one bit of the system to model the impact, and that included social care, so primarily community support services, so domiciliary care, intermediate care, which I know sits within my area but could sit within your area equally, as well as commissioned capacity within care homes, so it most definitely will.
Great. Just a second point, if I can, please, Jenny, just to comment on the intermediate care and reablement. I think it's fantastic that that's now becoming more integrated, and the intention is to go further with that, I know. And that will have a huge impact on our ability to enable independence and therefore help people stay at home. So that's a kind of real key service, I think, in terms of our future plans. So the more we can integrate that and develop it and expand where we need to, because I think there may be a need to do that as we develop it. I think that's really good news for the island to have that integrated.
Thank you. Charlie.
Thank you. Thanks for this paper, Oliver. It's good to have a more in-depth look at this particular matter. My question's around the additional staffing that you're going to bring in to address those winter pressures. So I've not been a NED for a very long time, but I do hear a consistent message around the need to recruit more to substantive posts and a real drive to reduce agency spend. So my question is, where are you going to seek to get this additional staffing from? You've got the money, but where are the staff going to come from?
Most likely agency, I would say.
Okay.
From the 7-day services point of view, we may look to our existing workforce to work additional hours under the bank.
Yes.
But thinking about an additional, so we were talking at recent primary care meeting around, potentially bringing in 3 locum GPs to work as essentially locum salaried GPs to be deployed. I think the most likely option, well, the only option for that will be an agency staff. Similarly, we would need to establish an outlier team within the hospital, because even during this winter, although it's been a bit, even this summer, even though it's been a really busy summer, we've seen between a ward and 2 ward of medical patients outside of medicine. Mm-hmm. So we do need a dedicated outlier team to provide more intensive support for those, so their length of stay isn't extended by them being outside of a medical bed, and so that would most likely be agency. So although it's not ideal, because we know that we're paying a premium for agency, I think the ability to advertise and bring somebody in for a limited period probably won't be possible given our timescales.
So I think what's going to be important there is a kind of post-winter analysis of what's happened and a clear statement that this was planned uplift in agency spend to address winter pressures, because what we don't want is that message to be misconstrued, say in the new year, that we've been championing the reduction of agency spend and a real drive for all of that, and then we've gone and just done it over winter. So I think the messaging is going to be really crucial, that this is absolutely planned, it's forecasted, and it's within, and it's controlled, and it's not going to just become something that then runs on into the spring and the summer and so on and so forth. Thank you.
Thank you, Charlie. Teresa.
Thank you. This is a really helpful paper, thank you, and does demonstrate the level of insight that we now have across our services. The thing that I would like to sort of see is that the capacity and demand analysis is going to be so incredibly important to us going forward. So understanding the level of demand that we're anticipating seeing in all of our lines of service, and translating that, if possible, to how much is that going to cost us extra to deliver? Because in that sort of fixed financial envelope that we're going to see, understanding that is going to be really, really important, and that will drive us to understand what transformation we may need to prioritise in order to manage that demand. And so this is really critical work for Manx Care. So I just wanted to ask Oliver, are you able to sort of identify when some of this work will start to be achieved? And have you got the right level of, I guess, resourcing in your team and capacity in order to protect doing this, what I consider to be critical fundamental work for the organisation to inform future financial planning rounds?
Certainly the development of the 4 transformation services that I mentioned, we've got really strong dedicated project management in for all of those developments. So although I'm kind of exec sponsor for all of those projects and kind of more involved in intermediate care, because that's a personal kind of personal I don't know what the word is. Passion, yes, for me, as that's a project that I started over 3 years ago. Yeah, we are lucky enough to have some really good project management that are dedicated to that. So it's not somebody doing that on the side of their desk. There is dedicated resources to that. Similarly, the demand and capacity work, although it's a piece of work that the performance team are doing, and we all know that they are, significantly under pressure at the moment because they produce the IPR on a monthly basis, and some other developments I'll mention a bit later. We have just recruited to 2 positions within the performance team that will provide that kind of performance business partner function for. There'll be one for the hospital and there'll be one for essentially the out of hospital space, so community services, social care, primary care, etc. So they will be the ones that are going to be delivering on that demand and capacity modelling, but also working very closely with the care groups to translate that demand and capacity analysis into action. So talking about the review of outpatient templates, talking about consultant team job planning, making sure for the first time, I think ever, that our demand, our capacity, whether that's consultant capacity, slots in clinics, physical space, actually matches what we need as an island. But as you say, that will quite quickly identify where there are gaps between our demand and capacity that can't be filled or can't be bridged by efficiency gains.
Yeah.
And that will show that actually in some services we do need an extra consultant or AMP and that will hopefully drive a much more informed financial planning process.
Good. Yeah. Thank you.
Thank you. Any other questions, Tim?
Just a rather specific question, really. Pre-COVID, when we would be discussing winter planning, we'd always be talking about seasonal flu and the impact that has. That clearly continues to have an impact, and I just wondered whether there's anything to say about preparations for seasonal flu.
Well, the seasonal flu programme is underway. The vast majority of it's been provided by primary care. We are offering co-administration but the uptake of that is quite low. Only about 25% people who go for a COVID booster elect to get the flu jab at the same time. So it's principally being provided by primary care. The cohort of flu is reduced compared to last year. So JCVI has recommended, I think it's 65 and above and clinically vulnerable, which matches the COVID booster. Last year it was 50 plus, which does leave us potentially more vulnerable. But I'm assured that the experts in the JCVI know what they're doing in terms of making that recommendation. That last year was a particularly bad flu season from an admission point of view. The data from Australia, which tends to be the kind of if Australia have a bad flu season, we have a bad flu season. They've had another bad flu season, so we most likely will have another bad flu season here. I guess from a winter planning point of view, the addition of more staff will help to alleviate that. But from my understanding of the initial flu uptake figures that primary care produced, the uptake is higher this year than last year, which is good. And the uptake of COVID is about the same as last year. So hopefully that increase in uptake, because as I say, we did have a bad flu season. Quite a number of people had the flu even though they didn't need admission. The anecdotal evidence is quite a lot of people had the flu. I think certainly the data from primary care shows that they had a lot more. So hopefully that's spurred some people on to have the flu vaccine this year, particularly in that vulnerable group.
And indeed, while it may not cause pressure for the hospital, it obviously causes pressure for primary care.
Definitely.
In terms of people wanting assistance. Thank you very much.
Any other comments or questions? Oliver, thank you for an incredibly helpful report. I think, just to echo Teresa's point, I think to know that we've got that data and we've got that level of detail now is incredibly assuring to the board. So thank you for doing that work. In my chair's report, I'm delighted to say that Sandra Cardwell has now joined the board as a non-exec. She was with us yesterday for our private board meeting, unable to join us today, unfortunately, but really pleased to have her on board the board. And she brings a skill set that will be incredibly valuable to us. So I'm really delighted about that, and thank the Minister for taking that through Tynwald for us. I think we are going to spend some time today talking about the money, and we're still in a very difficult position. I would like to thank all of the teams that are working so hard to manage their budgets whilst balancing the need for safe care, and that really is noticed by the board, and we will come on to talk about that. We've taken receipt of the Ofsted report, and I wrote to the staff to thank them for their hard work, both in preparing for that report, but also in working through the recommendations that are in there. We have come a hugely long way, and it is appropriate for us to note that as a board, as well as, of course, to note the ongoing improvements that must be made. So that's all I want to say. I could say lots of other things, but they're actually covered in the papers, which is a fantastic place to be as a chair, because really that's how it should be working. So, Teresa, over to you, please, for your report and your horizon scan.
Thank you very much, Chair. So, as ever, there's sort of a horizon scan which covers a lot of the detail of the extensive work that is going in within the operational teams. Next time at the board, we're going to incorporate corporate departments who support the ongoing work of Manx Care in their horizon scans. But just a few things to pull out from my report. Obviously, there continues to be a comprehensive focus and update on the vaccination programme. The report identifies that we reported an 83% uptake from the eligible cohort for the Spring Booster programme, which is significantly higher than the 71% on average for the UK. The autumn booster programme has started, and the eligibility for that programme is in the paper. We continue to have some issues with the Chester Street facility, and I think we're in discussion with the Department of Infrastructure as to where we would relocate the hub. It is on the risk register and is one of our extreme risks, which you identify in the risk management report. The executive will continue to take that forward. In October, the board made the decision that Manx Care would take over the running of Regent Dental Centre from the 1st of December, following that contract being handed back. So Hillside Dental Practice will come under Manx Care's leadership. This will secure the services for approximately 6,500 patients who are currently registered with that practice. The team are working incredibly hard. So Mel Pinkard and the team working incredibly hard to go out to advert for new posts to be able to support that practice, but also in discussions with existing staff who are part of that Hillside practice to transfer and discuss their employment transfer to Manx Care. As I say, there has been a backlog built up, and the focus will be on ensuring that all the patients who are on the books of Hillside receive their proactive treatments and checkups with a recovery plan in place for that. We've talked a lot about the importance of intermediate care and some of those transformation projects which are starting to come to fruition. So there is a more detailed update on intermediate care in my paper, because I think this is so incredibly important and will be part of the plans for winter in order to ensure we have appropriate step up and step down facilities from acute care. With regards to social care, integrated mental health and safeguarding, we have commenced the recruitment process for a substantive executive director of social care. Incredibly grateful for David for staying with us until next April, which will see us through that recruitment process. Interviews for that role are scheduled for early December, and I'm grateful for a number of people contributing to that recruitment process. The Safeguarding Board met last week, and Manx Care was able to provide positive assurance to the board on all the work in response to the CQC action plan, and also the adult safeguarding plan from the independent review, the Silman report, which was published in 2020. Again, and I would just like to thank David, but also Peter Tarleton, who had done a huge amount of work to move that work forward and provide real positive assurance to the Safeguarding Board. We also heard an update from Julie Gibney on how the multi-agency safeguarding hub was working out. That's sort of 3 months into that pilot project. It is going extremely well, I think it's fair to say. But as we anticipated, the level of demand coming into that service has increased. So that ability to share information and to publicise the MASH arrangements has resulted in increased demand into those services, but that was entirely anticipated. The island will mark Safeguarding Week on the 20th to the 24th of November, and all agencies that form part of the Safeguarding Board are really actively involved in that piece of work. Terry Banks, on behalf of Manx Care, is leading some of that. And what we will use that as an opportunity to really promote awareness of safeguarding. I think one of the key things which continues to come out is that fear and reticence from practitioners to share information, feeling they are breaching information governance and GDPR. And it's something we will need to continue to assure staff that sharing information in the context of safeguarding is entirely appropriate and indeed needs to happen. And I also wanted just to flag that, and it is linked back to the risk register, that the real importance of the Child and Adolescent Mental Health Services business case. It has been in development for some time. We are really, really keen to get this progressed. It is now with the Department of Health and Social Care to take it through Treasury. But I think we have, through the performance and accountability reviews, really understood the huge demand on the child and adolescent mental health services. The team are working so incredibly hard and with our partners to manage that demand, but we absolutely do need to see additional investment in that service and allow that service to focus more on early intervention and move to the Thrive model, which as a system we have agreed is the appropriate model of delivery for that service. I wanted to just pull out from the Horizon Scan, if I may, just a number of real positives around consultant recruitment. I think there are only 2 specialties within the whole suite of services where we have persistently struggled to recruit, and there is national and international workforce shortages in those 2 specialties. But we continue to see a really positive response to adverts for medical staff that we've put out. We have recently onboarded a new orthopaedic surgeon. We are in the process of recruiting to a second new orthopaedic surgeon. We've recruited recently a new paediatrician. Last week, we recruited a respiratory consultant, a new geriatrician and a new consultant in diabetes and endocrinology. There has been 2 new salaried GPs appointed and a further 2 in the pipeline. We went out to advert for dentists on Friday. We are interviewing tomorrow for anaesthetists, and there are 4 candidates that we are interviewing. And later in the month, we are interviewing for cardiologists, and again, there are 3 candidates. So whilst we would always like to recruit more, what I'd like to assure the board is, with the exception of a couple of specialties, and I will, they are dermatology. We've never managed to recruit a substantive dermatologist for some time, and gastroenterology. Those are the 2 specialties where we have been out to advert and not being able to make a substantive consultant appointment, but in all of the specialties where we have the budget, we have been able to recruit, and I think that's a really, really important message. And hopefully we will be able to make a breakthrough in those 2 specialties which we've had difficulty with. As ever, the risk management report. I chair the risk management committee. We have a new risk manager, and we continue to work hard and develop our risk management systems. They're really important, so we understand the risks at board level and we can make sure we are managing our greatest risks for the organisation. That has evolved, and what you will see in the risk management report is the incorporation of the financial risks. I think we will talk about finance later, but we have been working towards that transformation programme. We absolutely have acknowledged time and time again that the Sir Jonathan Michaels report recommended a certain funding formula for health and care, which hasn't materialised for all the reasons that we as a board understand. But obviously that set us on a direction of setting up Manx Care in a certain way with certain standards, investing in the levels of transformation that Sir Jonathan recommended were needed for a high-performing, high-quality health and care system. And now some of our financial issues are linked to the ongoing investment in some of those new models of delivery, which we feel are the best and high-quality services for our patients on the island. The risk management report also reflects some of the risks that we have around our IT systems. Coming back to that really important point from the Sir Jonathan Michaels report, we do need a single integrated health and care record, and we have identified a number of IT risks as we have understood our IT and digital environment better. We still have some of the workforce challenges. I mean, that is more about the budget, as we have understood the dependency and acuity of our services and needed to make sure that we have the workforce to be able to deliver safe care. And obviously things like CAMS are on there. So there is nothing on that risk register that I don't think the board has discussed in detail. And I think that should be assurance that sort of those key things which we should understand as a board are reflected in our risk management systems and our risk register. And I'm happy to take any further questions on the report or the horizon scan. Thank you.
Thanks, Teresa. Any questions or comments? I just had one around in the horizon scan. We talk about the lack of support or capacity, I should say, in the communications team for the fostering campaign, and I wondered whether you had an update for the board about the recruitment into that team. And
yes, so we have, following interviews on the 20th of October, recruited into the head of communications and engagement, so that will enable that team to be at full capacity. We're hoping that individual will be able to start with the organisation on the 1st of December. I'm also working closely with the team to be able to distribute some of the communications functions into the organisation, and have a sort of a distributed approach to comms, which I feel will liberate some of the team's capacity, whilst also giving services the freedoms to be able to manage some of their own low-level communications with support from the team. So yes.
excellent, thank you. Any?
Yes. Can I just add to that? So So in terms of the kind of fostering side of this, so in the absence of that professional support around comms, the team have been doing their own kind of promotion around that, so there's been some success in terms of people interested in that. Whether that translates into foster care is at some point we have to wait and see, but work is still ongoing around that to try and make sure we try and attract and recruit to foster carers.
Thank you. Thank you, David. Nothing else for Teresa? Nope. Then I will move us on to our reports from the standing committees of the board, two of which have met since the board last met. So quality, safety and engagement. First of all, please, Tim.
Thank you, Chair. Two issues we'd like to raise. One is a practical issue around the IPR and the reporting of that. As the board will know, that the Integrated Performance Report goes to QSE before coming to this board, where it can be assured and detailed questions can be asked. We've struggled with timescales on this, but just to confirm for the board that the version that the board will get in the future will be the version that the QSE has looked at and has assured. So that's just a practical issue, really. The other issue that we wanted to raise was around maternity services. And while locally there have been improvements within the maternity services, the services is not immune to international pressures in terms of, particularly in terms of staff and being able to recruit the right people. What has been agreed is for the service to look at a three-pronged approach with a short-term plan to see what can be done now, but also having a focus on the medium and the long term. So not putting off things which won't have an impact for a few years down the line, but looking at those now as well, which might be around ways to train staff and support staff in that training. I think the other thing that we want to make clear that this isn't an issue of funds and money. The money is there, but it's getting the resources and being able to buy the right resources with that money. So that's the plan, and that's what we wanted to identify for the board. Happy to take any other questions or for anybody to add anything further on that.
I think, I was reflecting this morning as I was listening to yet another story about maternity services on the national news, and I think, the Isle of Man is not, as you say, not immune to those pressures, and I think this is, for us a very significant issue about attracting and retaining staff in the maternity service, so that we can provide the care that women on the Isle of Man want. And I think that's always been the thing that this board has talked about is, balancing the right of a woman's choice with what we can safely provide as care. And I think the board is very alive to that tension and that issue, but having always to come onto or down on the side of safety, which means that sometimes we have to make really difficult decisions, like not being able to provide a birth service in people's homes. But we are very alive to that and very aware of that, and I think we've had some very good discussions through the committee, Tim, about, as you say, that kind of what can we do in the short term, what can we do in the medium term, and what's a longer term plan. So thank you. Anyone else want to comment on that? Thank you. Over to you then, Nigel, please.
Well, thank you, Sarah. Good morning, everybody. So, as you know, I chair the Finance, Performance and Commissioning Committee, and we met last week. And, I think I don't want to laboriously go through all of the items that are in the pack, but there is some very good stuff and some very good reading in the pack. We've escalated 3 items to the board, really. The capital infrastructure update, the pay award, and, of course, the September management accounts. And I'll deal with them sort of in reverse order and get to the September management accounts last. The capital infrastructure update, this was a very interesting discussion because one of the things we've been consistently asked for as a board is, but by our staff and by our personnel, is to give us fit for purpose infrastructure and fit for purpose properties. And it's very clear that as an Aaron comes up to speed and working with Jackie on this relationship with the Department of Infrastructure, who, as you know, look after our properties, that there are areas where we could be doing more and we could be working more efficiently and working better. And I think that, you know, a lot of the properties that we have are in poor condition, and we need to be looking at them through different eyes to see if we can use them more efficiently, possibly renovate them, and possibly even move them around. And it was very encouraging to hear that the relationship with the Department of Infrastructure is very good, but nevertheless there are a lot of frustrations and a lot of challenges in that area. It's obviously very good news to know that discussions continue with the Royal College of Nurses around the pay award, and there sounds to be a lot of positivity coming out of that. But, you know, in terms of planning, it's very important that we get on the front foot and we get ahead of the game a little bit, in that we have been battling with our people for 3 years now in arrears, and we simply must be able to control and to be able to plan for sensible pay, the right kind of relationships with our people going forward, and to get on the front foot. And I think this is a key issue in terms of planning, and there are some signs that this is actually going to happen, and I sincerely hope that we can move forward with confidence, because it's very difficult to talk about culture and to talk about behavioural aspects of our culture when we can't actually move to pay people properly and plan ahead. And I think this is a key issue. I think so I'm raising that to the board as well. The accounts, it's no secret that there's quite a lot of tension around money at the moment. I don't think we're alone, but I think that's cold comfort. We are spending a huge amount of taxpayers' money, and it's quite right that we should be scrutinised, and we should create that scrutiny on our numbers and on our accounts. And, you know, I'm very happy that actually at the Finance and Performance Committee that we meet monthly and we scrutinise and examine very, very closely not just the numbers, but how those numbers are made up and the process that goes into making those numbers up. And Ash may well, our business partner who's here today in place of Jackie, may well talk a little bit about that. And I would like to give you assurance that although the numbers are difficult, they are correct, and we've given them a really good examination. They get a lot of scrutiny. We talk a lot in accounting terms about that lovely lady Prudence. So we have actually taken a view that prudence should prevail, and where we see costs coming down the line that are probable, that we should account for them. That doesn't mean they're going to happen, but it means that it's probable that they're going to happen. And on that basis, we have pushed out the forecast by another £3 million this month, which some will take as very bad news indeed. But actually within those numbers, there are some very good news stories as well, which I think could be clouded by the headline figures. And I don't think we should allow us to be clouded by those headline figures, because there are some good news stories in there. And Ash, I think you'll talk to some of those in your review in the management accounts later on. So we have here, a financial supertanker, which is marching ahead. And sometimes it's very difficult to say something new about the accounts. But we are actually considering September's management accounts at the end of October. And that too is a good news story. So we do actually know exactly where we are. Furthermore, we have a very, very good detailed report on spend in the Finance Director's report. And I would commend this to you, and I would ask you to read it. Because if you go back to when Manx Care was set up, and you look at adopting the Sir Jonathan Michaels reports, if you look at our spend analysis over the 3 years that we've been running Manx Care, our spend is up a cumulative 18% from where we started. Inflation during that period of time has been running at 24%. So we've spent 18%, inflation has been running at 24%. We've actually received funding of 13%. So actually, when you look behind the numbers,
we're getting a lot more now. We're getting a lot more bang for our buck now than we were, notwithstanding the tensions and the pressures that there are within the system. And if you compared that to Jonathan Michael's fund, we're about half of where he predicted where we'd be. So actually, it's not such a bad news story. And I'll leave it there. I don't want to take Ashley's thunder, but I'll leave it there. I think it's very important that we have real context around these numbers, because they do tell the story, and it's not all bad.
Thank you, Nigel. Teresa.
Yes, thank you, Nigel. And I think those figures do give us some assurance that we are making most effective use of the funding we have got. But I wonder whether, so I think as an executive team and as a board, I think we have made appropriate additional investment where it has focused on safety and the compliance of our services. And so it is a question, do you think that for that broader assurance it would be worth bringing something through the Finance and Performance Committee which details all of the additional, and let's be fair about it, the majority of our costs are workforce-based costs, so over 75% are workforce. Do you think it would be a valuable piece of assurance to the Finance and Performance Committee to bring all of the additional investment in people that Manx Care has invested in over its 2.5 years, to provide the assurance this is around core safety and compliance of the organisation? Just a question.
I think that'd be very helpful. Not only for us as a board, but also for our stakeholders to have visibility of that.
Yeah.
And stakeholders, I mean Department of Health and Social Care, Treasury, and the Manx public.
Thank you. That's really helpful. I mean, I would agree for that transparency purposes. I think it's important to say that if we are overspending, where we have made those decisions to invest in additional workforce, people can see and evidence, where those investments have been made, why they have been made. Because I can just, recall off the top of my head, we have invested significant amount of money in making sure we have safe staffing levels in our emergency department, in making sure we have high quality staffing levels in our cancer services and our chemotherapy suite. In getting our information governance systems compliant, I don't think we have been indulgent in terms of where we have placed our investment decisions over the last two years. And I do think it's important we demonstrate that transparency.
I think we've made investments on the assumption that we are adopting the Jonathan Michael report and its recommendations, which were universally adopted by Tynwald. So it's not unreasonable to do that. But we live in different times. We talked about our first year as being the year of discovery. Then we went into COVID. Then we had other challenges on the horizon. So it's not unreasonable to do that. But the numbers do tell a story, and if you look at the stories behind those numbers, there are some real success stories beginning to come through. But it's clear that our cost improvement plan is slowing down. The stone cannot be squeezed anymore. So it's right and proper that we should factor that into our projections. But we're back to those issues of we cannot salami slice anymore. We're now into real transformation, which has an impact on digital, Manx Care record, all of these things. These are the big shifters that are going to make a difference going forward.
Thank you.
Thank you, Paul.
Just to build an echo, I think, on what's been said this morning, Teresa's absolutely right. We've been very focused on safety and quality as being at the heart of the decisions that we've been prepared to take. It's really, really encouraging to hear Nigel talk about anticipating what's coming downstream, and based on the probability of that, factoring into that our financial planning. I think that is a massive step forward, Nigel, and thank you for doing that. But I think it also touches on what Oliver said this morning in his deep dive analysis into the BAF, and where all this can come together is if we can start standing in the future, perhaps 10, 15, 20 years ahead, we can anticipate what's coming downstream. It's very easy using the exponential function to estimate the doubling time of something that's growing constantly, and we can do that with demand across all sectors. And if we do that far enough ahead, we can start looking at the probability. And if we put that in the real world where finances are constrained, what it does is it will help us make decisions around adaptation. How we might respond to that might not be the same orthodox thinking of putting more in and doing more and paying more and using more. It might be thinking very differently about how that problem might be tackled in the future, taking a much more proactive and preemptive approach at mitigating some of that demand 10 or 15 years ahead of it being needed. And so for me, this feels like a huge step forward in our maturity as a board and in our thinking. I think it will give us incredible insight. I think it's very important.
Thank you, Paul. I think if I could come back on that, I think that's absolutely right, Paul. And you know, the year of discovery, the first year, the second year, getting to grips with what we've got. And I detect a shift, and you might say, well, he would say that, wouldn't he? You know, but I detect a shift from reactivity, from reacting to the storms of life that are thrown at us, to proactivity. Dreadful word, but proactivity, looking forward. And I think, you know, on the one hand, you could say, well, it's not our job. Our job is delivery. But actually, it is our job to provide our stakeholders with the solutions and the ideas as to how to react to this going forward. And sitting behind all of this, we've got our island plan, which is very key from a government perspective. That is projecting and hoping for an increase in population. And that will lead us to activity-based costing, clinical coding, which we're now introducing. All of these things enable us to predict with more certainty what the future is going to look like. And we almost, it's incumbent upon us, we almost have a fiduciary duty to do that, as well as managing the service, to look out 15 years and say, hey folks, where do you want to be in 15 years? And we all agree to certain tenets around that, but funding is going to be a challenge.
Thank you. Any other comments or questions at this point? No. So it's nearly 10:20 and we're due to have a break at 10:45, but I suggest we take it now and have 15 minutes and come back. Come back at past actually, if that's okay with everybody. Thank you.
Thank you.
Okay, I'm going to draw us back to our agenda, if I may, and we're going to the Integrated Performance Report, and I'm going to start with you, Paul, if I may.
Well, sorry, I just...
No, you didn't.
I wasn't expecting that.
I thought I'd do them in the order that they're on the agenda. I should have given you some warning.
I'm extremely grateful that you have. If you can bear with me while I try and chew and simultaneously talk at the same time. I want to highlight a few things, if I may. This has been another strong performance on quality for Manx Care. Particularly, if you may indulge me a moment while I highlight this, because in spite of what have been intensifying operational challenges, we're still doing the right thing for patients and putting patients first. So I draw attention in particular to our continued progress on the controls to proactively manage the risk of a never event. It's great that we've gone beyond 2 full years without a never event. I know that when I say that, there's always the risk that we might have something crop up. But for every month that goes along, it demonstrates that we're serious about safety, we're doing the right things, we're being proactive, and we're anticipating and mitigating that risk well. Excuse me. I also draw attention to the relatively low risk that we have in relation to medicines management. The point I want to make here is we have had 0 incidents recorded that have involved a medication problem with a harm. But we do have medication errors in the medicines management process, which says loud and clear that we are reporting near misses, we're acting on them, and we're learning from them, and we're using them in a way to develop our practice, which again is a sign of strength. I'd say the same for falls management. We do have people who fall who are in our care, both in community settings and in hospital. But our approach to the falls risk assessment and intervention means that it's helping to keep harms lower than they would otherwise be in England, for example. We compare ourselves with English hospitals, and our rate of harmful falls is much lower and is consistently lower even though we do see falls reported and we're learning from them. That's a tribute to the staff on the ground who do incredible work every single day, in spite of all the challenges, to keep the needs of the patient uppermost in our thinking. We've done incredibly well on venous thromboembolism prophylaxis, which again is another proactive intervention to reduce the risk of blood clots for people coming into hospital. Our performance on that is exceptionally good. One of the best I think I've seen for an acute provider. And we've seen improvement in the two areas that I know the board have had an interest in recently, namely Clostridium difficile infections have started to reduce, and pressure sore acquisition, which is also reducing. We've taken the issues that underline the reasons why those have reduced through the Quality Committee. I don't intend to go through them here if you don't need me to. We've got some areas of strength as well. If I can draw your attention to antimicrobial stewardship, you know that I've made no secret of my need to improve our antimicrobial stewardship compliance. If I can draw your attention to the graph which illustrates the 48-hour to 72-hour review of antibiotic prescriptions by a senior doctor. And although we're not hitting the threshold, which I purposefully set very high, I think you will agree that it shows continued strength and performance in the right direction. And this month we've achieved 88%, which is the highest it has ever been since we started to record this at Manx Care. And that's nothing that I've done other than try to encourage my colleagues to focus on it. The success belongs to the staff on the ground, particularly the medical staff, the consultant teams, and Dr. Pam and others who help to keep a focus on this. And because we keep a focus on it, it's the currency of leadership, and it's what people pay attention to, which is great. Learning from deaths is a process that we have implemented to review the people who have died, to see if there's any learning that we can take away and change our practices. And you can see from the information there that that's becoming deeply embedded now within our systems of governance. And whilst we all want to see improvements in coding so that we can do clinical benchmarking and more sophisticated statistical analysis into mortality ratios, this is a very important building block in being able to achieve that. And it's an illustration of how the culture is evolving inside Manx Care to being open and transparent and willing and able to learn from these things. We have seen a slight drop in nutrition and hydration screening. You'll see from the graph there that that's unusual given our recent performance. My instinct is that is linked to some of the challenges we've experienced around Opal 4 and operational issues and staffing issues. But expect to recover quickly from that. I see it as a blip and nothing more than that at this stage. And I'd like to just also acknowledge the continued work of the MCAL service, achieving our commitment as a board to resolving concerns that are raised with us as far as possible on the day, or at least within 7 days of those issues being raised with us. And you'll see the figures for MCALs are quite astonishing. And in addition to that, we've restored performance on duty of candour and restored performance on complaints handling. So all in all, I'm painting a positive picture because it pays tribute to the commitment of the staff on the ground to put the patient first, think about their safety, manage their safety and improve quality of care. And by and large, the indicators that we have in that regard are showing that we're doing that. I'm happy to pause, Sarah, if any questions.
Thank you. Any questions? Oliver?
May I just ask about the effect under effective wellbeing services and about West Wellbeing Service contribution to reduction in ED attendance? And I know you have noted some concerns about, there's some notes about how that data is collected just below that. But can you expand on how that data is, how that's calculated at all? I can't quite picture how that would be calculated.
Not sure I can, but one of my colleagues might be able to assist with that. I'm not the executive lead for that indicator.
Okay. I believe it's a extract of ED data from people who were registered with PLGP practice, and basically a kind of trend line going down. So it's not an accurate. It's not kind of.
Proxy measure.
Yeah, it's a proxy measure.
So it's just people in that area.
Yeah.
Okay. So it seems. How is that then being attributed to the wellbeing service? How is that justified?
Well, it was a measure of ED attendance before, so I think they were collecting it for about 18 months, 2 years before, and then it is just trending down. You know, the difference between pre and post wellbeing partnership. It is
existing.
Yeah, it is a proxy measure. It's not a kind of 100% accurate, because I know will be other things at play.
I mean, my other role job is a PLGP.
Yeah.
I mean, I'd like to think maybe we might have had something to do with it as well. I'm just we do have a little bit of we do input into our patients as well, and I hope we can contribute to reducing their ED attendances. I'm just wondering if this is the right way to present this data. Really, I think it's.
Well, maybe it's a conversation to have offline and then come back to the board with a bit more explanation, Oliver, about how we. What I was going to say, how we attribute the if there is a fall in ED attendances, you know, how do we work out why? I think that's the question that the board is asking, because. If we know why, then is there some learnings from that we can apply in other areas of the island? And, you know, if one area is doing a particularly good job at some, you know, whatever, I don't think we've got enough information to be able to answer your question, Oliver, is what I'm saying, really. And I think if I could ask you, Oliver Radford, to take that away and have a bit of more of a look at that, and then we can have a conversation perhaps at the next board meeting. Okay. Any other comments or questions for Paul at this stage? So it should come as no surprise that I'm coming to you next, Marina, as the medical director.
Which one is mine? That's about the death. Page am I think I'm lost with all the pages.
On the integrated performance report.
Yeah, is that the one about mortality?
Oh, yeah.
I've got too many pages in front of me. Because I haven't specifically prepared anything.
I think I've covered. In fairness, I think I've addressed the issues that have been for Marina.
It was the mortality that Paul has covered already.
Okay.
So I think, just to repeat, so I say something, is that this is an area that Alison and Dave Headley, the medical examiners, have worked very hard with Dr. Pam in establishing the mortality group. And the level 1 mortality, we can be assured that is 100% taking place in the hospital. The only bit that has not yet been established is level 2 mortalities. But that can't take place until we have people identified from every care group who will then pick up cases that are randomly chosen to have the level 2 review. So, as I said at last month's, the last public board meeting, this is work in progress. In terms of benchmarking, we can't do that until the coding data is available, as Paul mentioned earlier. So that's the main thing that I have to report on from mortality. So it's work in progress.
Thank you. Tim?
Just to say, I think Marina underplays the progress which has been made in this area.
Thank you.
It's the QSE had a very full and helpful report from the medical examiners at our last meeting. I think it's Dr. Toole.
Dr. Hoole.
Dr.
And
Hoole.
Dr. Headley.
Yeah, Dr. Hoole attended and very helpfully and fully explained the work that's been done. So for the first time, we do have all deaths being looked at in this way, and I think that's a real step forward, given what was reported to QSC about 9 months ago. So I think it's a real area of progress, and we look forward to that being taken to the next stage. And I have full confidence in the clinicians involved to progress that. So thank you very much.
Thank you. And in terms of child mortality, we have the assurance from paediatrics that their data is sent to public health, and that data is incorporated with the Northwest data. So unlike adults, where we need the coding data to get the shimmy, for the children, our data is incorporated in the Northwest data. So we have that assurance from the child mortality.
Thank you. David.
Thank you, Chair. I'm happy to report generally positive position across the care group at the moment, with a few exceptions, of course, which I'll pick up as I kind of talk through each of the service areas. So in terms of mental health, average length of stay has been fairly good and consistently good against targets, with some further improvements in September. There's a few kind of dips in some areas, but we understand why that is, and staff are working well to make sure that we keep to those targets. Assessment times, which are response rates, where people are seen within 24 hours, and the care packages are developed within 2 weeks, both currently sitting at 100%, and again consistently good performance in those areas. Response times, which are 1 hour response time to ED and 3-day follow-up following discharge from the service, again both exceeding targets, one at 90%, one at 100%. Waiting lists and demand across, in particular, CAM services, Teresa picked up on earlier. So there are business cases that are in at the moment. Hopefully, if we're successful, that will start to address some of those waiting lists, which has been a concern for some time. But we have got those plans hopefully in place, and we'll get a positive result as soon as we can. Adult social work, re-referrals, good performance. That's been an issue for us in the past, where we've had a number of re-referrals coming through following closure. It's now been at 0% since March, which is good performance. And that's a combination of improved closure processes, where team managers are sitting down much more closely with social workers and agreeing processes for closure, and some data cleansing as well, and some data recording issues. So hopefully that will keep that level, or very close to that level, as we progress. A focus for us in adult social care is around completed assessments within 28 days. That's always been a concern for us. It's a real focus at the moment, and we're at about 23% in terms of people doing that. The main reason for that is around LD services and complex cases generally, and we know they take longer to complete assessments because we are working in a multi-disciplinary environment, and that often means trying to get people together at fairly short notice sometimes to complete those assessments. So we're working with partners to try and reduce that 28-day assessment time frame. Receiving a copy of assessments is now at 100%. That's been an issue for the last couple of years. It's now been improved. Again, mainly down to data. If I'm honest, people weren't recording that appropriately, so that's now been recorded. And so that's seen a significant improvement. I think generally with adult social work, I believe that actually we're not necessarily measuring the right things. I think it's very limited in terms of what we measure, and we can improve on that. So we're meeting with BI colleagues we've met already to look at some of the ASCOF, which is the Adult Social Care Outcomes Framework from the UK, to see whether there's some measures in there that actually would be helpful for us and more meaningful in some cases, and help us understand our performance, whether it's good or bad or indifferent. So we're doing that work as we speak, and we're also looking at quality measures rather than just KPIs. So what does it mean for individuals, and how do we capture that? So I think that's going to be work that's ongoing over the next few months, I think, and probably beyond that. But we have started that work, which we've been wanting to do for some time, but never really had the capacity to do that. Children and families, reviewing activity, all performing well, with the exception of complex needs reviews. So that's currently sitting at 48% and the target of 85%. The good news is we understand why that's the case. So there are 13 that are out of timescales, and the majority of them, which is 6, is down to, again, professionals and other agencies not being available for those reviews. So again, it's about that multi-agency environment and making sure that we are working more closely with those partners to get them involved in those reviews where we can and where we need to. Children contributing to reviews, all those indicators are above target, except the complex needs. And the reason for that is that we've got a dedicated worker in all other areas, children's services, who are working with individual children and young people to help them engage much more in the process in terms of reviewing, except in children with complex needs and children with disabilities. So the team are looking at that to see how they can transfer some of that good practice across the board. And I think I'll stop there if I can, Chair. I'm happy to take any questions, comments on that.
Thank you. Any questions? Yes, Tim.
Just a comment. I'm really glad to hear that starting to look at the performance data. I understand that capacity has been an issue. I did share some of the reporting of some English local authorities with the business support within adult social care some time ago, and really pleased that that's now being taken up and focused on.
Thank you.
Thank you.
In the complex cases, David, when you say there's perhaps issues with engagement with partners, are there particular issues, or is it a sort of general lack of resourcing?
Yeah, it's been around capacity, Chair, if I'm honest, and the number of reviews that are coming through, and then getting people to be able to commit to those reviews is challenging for all agencies, really.
And does that have a knock-on effect in terms of next steps for a child, or...?
It could do in terms of any kind of care plan or care package that comes out of those reviews if they change, generally. But the waiting time for assessments has always been an issue, I think, in social care, 28 days, and there's a lot of questions around whether that's appropriate these days, given the complex needs and how long it takes to do a comprehensive assessment of somebody, including a whole range of different agencies and organisations. So I know in the UK they're looking at that target. Is it a meaningful target, really? Because people really fail to hit that quite often, despite having adequate resources in some cases. It's still a challenge.
Okay, thank you. Any other questions or comments? No. So, Oliver.
Okay. Do my usual kind of three things going well, three challenges or areas of challenge. So the first one mentioned recovery and restoration a few times already today, and that's continuing to impact positively the waiting lists. So in total, the R&R programme has delivered 3,324 surgical procedures. We've seen an 83% reduction in the ophthalmology day case waiting list. That service, that the R&R contribution to ophthalmology is now finished, and we're now running on business as usual. And we have our visiting consultant who comes in to do 20 cataracts per day for a long weekend once a month, which is keeping the waiting list in check. As we mentioned earlier, 40% reduction in orthopaedic waiting lists. We haven't quite met our target waiting list figure, but we plan to do that by the end of the financial year. But it's worth noting that that the transition from synaptic facilitated services to the majority of Manx Care delivered services is almost there. It's just the remainder of support remains within the ward, and that's just recruitment dependent. But we have a plan, as I say, to have a fully staffed elective orthopaedic ward by the financial year, and 33% reduction in general surgical waiting lists, with a plan that we finish the general surgical synaptic programme by the end of November. Ambulance response targets continue from categories 2 to 5 continue to be significantly less than the national standards, which is great. And then finally, we've discussed here both theatre utilisation and theatre cancellations, but glad to report that for the last 3 months our theatre utilisation has been above 80%. With September being reported as 80.6%, and we are attributing that to the fact that we now have essentially an elective admissions lounge based within the day procedure suite. So anyone who is due to have an operation that requires an overnight stay starts on DPS rather than having to wait for a bed on their destination ward. that just means that they can then go to theatre on time rather than waiting for a bed, which has meant that our late starts have reduced quite significantly. And then similarly, theatre cancellations on the day, we've done quite a lot of work validating that data, both from a reasons point of view, and we're going to do a deep dive on that in the next month. But we've now seen quite a significant reduction. September was 33 cancellations on the day, which is significantly less than the year-to-date run rate, and we're seeing consistent good performance on that. In terms of areas of concern, cancer standards or cancer access standards continue to be a concern, although we are seeing stability within the 28-day faster diagnostic standard. We achieved 65% of that in September. 2-week wait continues to improve, so we've seen this is the third month of improvement around 2-week waits, but we are reporting 67% of patients seen within 2 weeks of their referral, but the median wait is 13 days, so that the median period of time that people are having to wait to see the consultant from date of referral is 13 days, but the issues remain in terms of particularly workforce pressures within endoscopy that are meaning that particularly the upper and lower GI cancer sites are struggling to maintain the performance against the 2-week wait standard. We are looking at aligning ourselves to the new national NHS cancer waiting times, which were released just earlier on this month, which sees a much more of a focus on the 28-day faster diagnostic standard rather than the others. But clearly there does need to be a focus on all of those standards so that we maintain the kind of momentum through the pathway for our patients. I've attended 3 of the main cancer PTL meetings, which are our patient tracking list meetings on a Friday, and I'm assured by what I've heard in both of those meetings that everything is being done around maximising our performance against all the cancer sites. But as I said, we do have some more chronic issues. Teresa mentioned dermatology and gastroenterology. They are key parts of two of the big cancer sites that we have, upper GI and skin cancer. So our inability or our struggle to recruit into those posts substantively is having an impact, as well as issues in endoscopy. But that continues to be a significant area of priority of me personally and the cancer team. Dental allocation list. We've mentioned dental earlier, and since the last public board that gained some media attention just in relation to our deteriorating position around the waiting list for dental. We've continued to see an increase in that, so the dental waiting list has increased by 759 people since April of this year, which is a 21.6% increase. We've done we had a workshop between ourselves, the primary care team within Manx Care, colleagues from the AGs and the DHSC, to see whether there is anything that we can do to kind of maximise our contractual levers to drive performance. Unfortunately, there's very little that we can do, as advised by the AGs, around our ability to amend or do anything to the contract, which is unfortunate. We made a decision at that workshop to reintroduce the dental advisor role, which is somebody who's employed by Manx Care on a sessional basis to support dental contractors in their management of their waiting list, management of their claims against the units of dental activity. That was a service that was previously provided to us by the NHS Business Services Authority, but that was withdrawn a number of years ago, and was that withdrawal was missed by our dental contractors. So we are looking to reintroduce that to provide a bit of clinical support to dental contractors around their waiting list and activity management. We are continuing to push forward the unification of the units of dental activity payment, which we believe will spur a couple of contractors on to move to the new contract. And as we mentioned earlier, we are taking over Hillside, which is already our second biggest contractor. But what we're going to look to do is to try and increase the number of UDAs within that practice to take patients off the waiting list. Unfortunately, there isn't anything that we can do, significantly at the moment to reduce that the number of people waiting. At the end of the day, to reduce that waiting list, either we need a significant injection of cash to increase the number of units of dental activity that we have available to contract out, or introduce some kind of limitations or eligibility criteria, which I know I mentioned last time. But if we don't either increase the capacity or reduce the demand, I think our ability to maximise efficiency is, whilst there is some opportunity there, it is limited, and it's not going to solve the increase. And we are continuing to see increasing additions onto the waiting list. It's interesting to note that the number of patients who have been allocated to a dentist really hasn't changed for the last 10 or 15 years. It's just the waiting list that has increased, particularly over the last 12 months. And then the only last thing I was going to mention is just around radiology. Our demand in radiology is relatively stable year on year. There's differences in terms of demand in different modalities as technology changes, but overall demand is relatively stable. We did, however, see a 22.8% increase in demand in September. That is principally from our inpatient activity, linked to the increase in demand, particularly in September. Around 58.6% of patients received their test within 26 weeks, which we are within our operating plan, aiming to increase to 99% by at the end of March 24. We do have some initiatives already in place. So R&R, Recovery and Restoration Phase 2, did allocate some funding to enable us to recover the cardiac CT waiting list and the ultrasound waiting list. And both of those are, once the R&R Phase 2 programme has finished, both of those modalities will be down to less than 6 week wait, which is great because cardiac CT was around 8 months previously. And we are looking to recover the remainder of the imaging waiting list through the R&R3 business case. That includes other imaging modalities that sit outside of radiology, such as cardiorespiratory physiology. And that's it. Thank you.
Thank you. Any comments or questions? Nigel?
Yes, please. Thanks, Sarah, through you. Oliver, I'd just like to ask you a slightly pejorative question, if I may, to draw a point out, because, I know very well the hard work and focus that there is on these statistics, but you will also know from many discussions my genuine dislike of the perception that we slavishly adopt a UK standard in terms of measuring ourselves, because my argument would be, well, why are we aligning ourselves to the UK? I know there are very good reasons for that, but actually we're a small island. We should be aiming to shoot higher than the UK. We should be outperforming the UK standards because we can see what's happening in the UK to the NHS, and we should be aiming to do better than that. So it's around cancer stats, really, and very sensitive, very difficult area. And again, I know the hard work and immense application that goes on within the team. But this 28-day business, we are getting rid of one standard which we're not performing against, and we're seemingly expanding it from 14 to 28 days. Is this just a SOP to enable us to seem as if we're performing better, or are there real scientific reasons behind that adoption of that standard?
We will continue to monitor and measure ourselves against the 14-day standard. That is part of our reporting pack to the DHSC. The new cancer waiting time standard says, specifically says, don't throw away the reporting against 2-week waits and concentrate on 28-day, because if you forget about the 2-week wait first contact, then you do start to end up pushing everything towards the end. We have quite a difference in terms of the diagnostic pathways on Ireland. For example, breast and colorectal, pretty much all of that pathway is delivered on Ireland, not just the diagnostics, but also the treatment. There are others, such as haematology, that we are extremely reliant on UK providers to diagnose, particularly, the specialist kind of molecular and genetic labs that live in Liverpool. We are dependent on those, and there are other diagnostic modalities that we don't have, that we are reliant upon, such as PET scanning. So I believe that a move to a 28-day access standard is another way for us to measure ourselves. At the end of the day, whether somebody gets seen at day 12 or day 16 by the consultant really is fairly arbitrary to individuals, whereas our ability to physically feed back a result by a consultant within 28 days, I think, is a lot more meaningful to people.
Yeah, there's also the case of patient choice in this as well, isn't it? That's an important factor.
Mm-hmm.
Teresa, then Paul, then David.
Yeah, I think, certainly the cancer plans and the cancer targets, having been involved in some of that in the UK, there is a strong evidence base behind every one of those cancer standards. And, the faster diagnostic standard arose from people having prolonged cancer pathways and treatment way outside of the 62-day standard, which we know is linked to positive outcomes in cancer treatment. So the fact is that if we can aim for all of our patients to have received a diagnosis from which treatment can begin by day 28, that will absolutely positively impact on their outcomes and their recovery and their treatment from cancer. So I do not see this as in any way a sort of a fudge. It is absolutely something which we must make sure that, we're at 65% now. The new national standard from the UK is going to be 80%. And it's something we should continually strive for, because as soon as you have a diagnosis, you know what the treatment looks like. And that will impact on outcomes.
Thank you, Teresa.
I think, Nigel, I think you ask an incredibly important question. And I think as a board, we should attempt to answer that question from the perspective of the person who's using the service. And I don't know if you got a chance to watch Rod Gilbert on the BBC last night, who's been treated for head and neck cancer. So it's a very moving story. 1 in 2 people will get cancer in their lifetimes. That's how the statistics have moved on. And if you were to ask people who are in that process, does it matter if we are fast? I think the answer would be a deafening yes. And I think we must put our efforts behind this. It's very important.
Thank you, Paul. David.
In a similar vein, I think, Paul, in terms of, I think it's a good debate to have, isn't it, between performance management and quality assurance around some of this stuff, and how we set standards or adopt standards from elsewhere and performance indicators that go alongside of those. So the debate around the 28-day assessment, for me, okay, it's important that we get to people fairly quickly, but it's more important in terms of the outcomes from that assessment, the quality of it, and how we're engaging people in that assessment process. So I'd be more interested in thinking about how do we set those quality measures that help us understand people's experience and the outcomes from some of the activity that we have. Now, I'm only speaking from social care here. I think that we struggle to even have a performance management culture at the moment, if I'm honest. So I think that's maybe a starting point. But there's something about how we then morph into more quality assurance rather than just looking at some of the facts and figures around these things and some of the measures that we currently have. And I think that's a journey that we need to go on, personally, in terms of quality assurance. And the quality assurance framework that Paul's already started some work on is something I think needs to be across not just Manx Care, across government and across all our partner agencies out there in terms of what does quality look like, how do we measure it, how well are we doing, and how do we know? So there's some kind of fundamental questions that we need to put underneath some of our targets that we're setting, some of the standards that we're agreeing to. And how we get to that point might take some time. But I think the conversations are happening now. Certainly from when I was here 2 years ago, we didn't really have those conversations, whereas now I think we're having them, and there's quite a bit of work starting to materialise, I think, around how we do that, and how we do that collectively.
Oliver and then Marina.
Thank you. So, in terms of what Nigel was saying about, you know, local targets for the Isle of Man, I mean, I think I'd like to sort of perhaps sound a note of caution about that. I mean, I think as registered practitioners and GMC regulated, I think our comfort would really be knowing that we would be following something recognised like nice guidance. I brought the nice guidance about cancer referrals up in front of me now, and there are, and I think clinicians would be very keen, certainly in primary care, probably elsewhere, to know that the reporting is against specifically what NICE says, or if there's some other framework, if there's an Irish version or a Scottish version or European or whatever, to know and have absolute clarity that this is the standardised framework and guidelines that we're reporting of. And the guidance has changed. It does talk less about 2 weeks, and it talks more about 28 days, and I think that's important. There are still some things that have urgent, which they define clearly as 2 weeks or 48 hours, and I don't know if maybe even it would be worth getting even more granularity into that. So I have in front of me upper abdominal mass, consider urgent, this is for a direction to a GP, consider an urgent direct access ultrasound scan to be done within 2 weeks. And that level of granularity is, I believe, what Manx Care should be looking for, so that we can say, tick off every point on a nice guidance, if that's what we want to follow. This is what we're achieving, this is what we're achieving, this is what we're achieving. And the other point I make, if I may make, is we're focusing very much on cancer, and rightly so, because we need to focus on it. But there are non-cancer, serious, urgent referrals that are made that I wonder if they kind of sometimes get a little bit forgotten or left to the side. So, for example, we have heart failure, for example, and NICE has very, very specific guidance about referral criteria. So BMP, which is a blood test to measure how bad someone's heart failure is. If it's over 2,000, refer within 2 weeks. If it's between 400 and 2,000, refer within 6 weeks. TIAs and suspected strokes, for some people it's 7 days, for some people they should be seen within 24 hours. And what I think would be really good is to branch out from not just these cancer points, but to these other serious illnesses that cause morbidity and mortality, perhaps similar to cancer, and get ourselves assured that we are meeting those NICE criteria across the piece.
Thank you. Thank you, Oliver. Marina.
Which we will need an integrated care record for.
Yes.
Because unless you manually do that, you haven't got the ability, I don't think, correct me if I'm wrong, to be able to demonstrate at an electronic level that you're meeting those targets in the surgeries.
So these would be targets. So referral to ultrasound, let's say within 2 weeks, that would be, I don't actually know how Oliver collects his data, but that would be, I mean, so you know the time, you know when it was referred, you know what it was referred for, and you know when they have an appointment. So it should be extractable in radiology. And likewise with the stroke pathways, it goes through, what are they called, PIC? Goes through PIC, they know when it came in, they know what it's for, they know when they had an appointment, so that should be extractable according to whatever.
Manually, per speciality, right? Not at a central level.
No, it's all extracted centrally from Medway or Careflow, but it's relying on the referral date. It's all kind of the time from referral date.
Okay.
So it's not integrated in any way.
Right.
The letter gets, Oliver types his letter, or somebody in Oliver's practice types his letter, gets emailed over, scanned in, then graded.
And that's not
Yeah.
I think what we, without getting into the detail of how all of this is collected, I think Oliver's point is well made, which is, you know, there has been a tremendous amount of work done on cancer, quite rightly. What else would the board like to be assured of in terms of, you know, seeing patients in a timely manner? Marina?
Yeah, thank you. Sorry to...
No.
Thank you, Oliver. You said that very eloquently. I wanted to say something about that, but I won't repeat what you say. I'm going to take it on from an integrated point of view because you've already made my point about cancer. So I'm going to talk about mental health. Specifically, there is a whole area where we don't even capture, for example, the adult ADHD pathway. There is no pathway into adult mental health service. These patients have a high degree of morbidity and they can't access services. And so whilst we may focus more on the acute hospital and acute medicine, there's a whole area of psychiatry that patients are not getting any service for. Now, we're not unique in this case. It's pretty, I wouldn't say similar. It was similar in the UK, but there are pathways. Patients go on a waiting list. Here, there's no pathway into the service. And this is very unfortunate because it has huge impact for our children going to university who maybe weren't picked up in camps and there's 5-year waiting lists in camps. For adults, especially on the island, in the gaming profession accounts, where a lot of people with ADHD might have an attraction to these fields and medicine because they can hyper-focus on, and they have to pay privately and they have to pay for the medication. Some of these medications cost £500 a month. Imagine having to pay that for the rest of your life. So I just want to labour that point.
Thank you. I don't know who was first, you or Nigel. Sorry, Teresa.
Well, thank you, Sarah. Yeah, Oliver, I'm really grateful for you pointing that out to me, and really grateful for you expanding it beyond the cancer pathways as well to the other issues that we deal with. And I suppose I asked the question because I was concerned that the 28-day could be perceived to be a fudge, and I think I'm getting the satisfaction that it's not, and there's real objective evidence behind that. But it raises another point about which I'm very concerned, and I think where we could make a difference as Manx Care, and that is not just the clinical journey, but the emotional journey of the patient. And it's odd for an accountant to be speaking about that, but I know. But I think, you know, I'm sure we all have friends and family and maybe even individuals around this table who've been in this situation. That horrible period between initial examination and either a chat with your consultant or a diagnosis, where anecdotally you're very concerned that something horrible is going on, but you're not sure what it is, and you're not sure what the pathway is out of it, whatever that might be. And you know, I would like to think that we could be absolutely first class in terms of communication and support in that horrible period of time where there is desperate uncertainty and desperate mental stress going on, and that we could handle that really well, and we could assure ourselves that we have provisions in place to handle that really well from the perspective of the patient.
Thank you. Teresa?
Thank you, Sarah. I think this raises probably a broader and more fundamental question. So we've talked this morning about really needing to understand the demand on our services against the capacity we have. And one of the key areas of risk for Manx Care, but one area we've been grappling to understand what is a clear baseline, is our compliance against NICE approved technologies, treatments and standards. Because NICE, and it goes back to whether we should or should not compare ourselves to the UK NHS, but NICE has been approved in the UK for 22 years. And that gives, and by the nature of NICE, they are approved because they have a clinical effectiveness and they have a cost effectiveness. So we know these are interventions, drugs, technologies, which generally have been proven to have an evidential benefit. We've worked hard to understand the baseline in terms of what level of NICE compliance are we at. I think the gap we've recognised is how do we then put ongoing monitoring, because often if you're on a NICE approved drug, you require the ongoing monitoring for that. There is still a considerable amount of work to do, but as we have to understand what will be the totality of cost and demand on healthcare going forward, the compliance with NICE standards across our health and care system is, I think, probably one of the most important things we need to do next as a board. How do we get to a compliant state that protects our clinicians, it protects our patients, it offers equity with the UK NHS, and we know fundamentally, because they've been through an approval process, these are the right interventions which have a positive impact on patients. So I think it's perhaps something we might want to consider having a little bit more focus on at the board, either next time or the time after, as we make sure we have the right focus on this piece of work, particularly as we sort of plan what the delivery of NICE is going to look like, and how we sort of effectively challenge ourselves to do 22 years of catch-up, effectively. Which is
I think the board
small order.
would welcome that, Teresa, and I think that, you know, if I can leave that with you and your colleagues to say whether it's the next board meeting or the one after, but I think that would be a very valuable piece of work for us to do.
Yeah.
Thank you, everybody. That's been a really important discussion. Going to move us on now to a verbal update about the pay negotiations, please.
Thank you. So we've obviously not resolved the pay dispute for 22-23. We entered into negotiations with the Royal College of Nursing on the 5th of October, facilitated by MERS. That was a very productive meeting, and on the 9th of October, following some further funding being made available from Treasury, which we are incredibly grateful for, we were able to put a revised offer to the Royal College of Nursing and all other staff side organisations within the MPTC and NJC group, which, as a result of that, the Royal College of Nursing did take the decision, which we're very grateful for, to stand down their planned industrial action, which would have taken place in the last couple of weeks. There has been further discussions with the totality of that staff side grouping, and we wait feedback that has been subject to further ballot. But I think we have managed to positively progress those discussions. Obviously, we haven't even got on to talking about 23-24 yet, with both our medical and dental colleagues and our MPTC NJC colleagues. But in light of the discussions we had at private board yesterday, I think we will be able to move that forward quite quickly. And obviously yesterday we did have the confirmation that the PSC has agreed a 6% uplift for 23-24, and obviously about 37% of Manx Care staff are PSC employees. So that sort of does move that pay negotiation on slightly, and I hope to be able to give a more comprehensive update at next time's board. But it is moving in a positive direction, I'm pleased to say. And Anne, was there anything else you wanted to?
Any questions or comments? Thank you, Teresa. Coming to you, David, then, please, for the update on the Ofsted inspection.
Thank you, Chair. There's a report in the pack, which is a presentation that gives not just the highlights, but a bit more detail in terms of progress and action plans that have been developed. I just want to remind the board that the inspection happened between April and May this year. There were two elements to that inspection. One was the residential side, and the other was a wider kind of social work inspection, looking at some of those associated services to the social work element as well. I think important to highlight the self-assessment that went in prior to the inspection, and the fact that I think that was very honest and very open about our shortcomings and challenges that we have across children and family services. As a result of that, I think what came out of the inspection weren't really any great surprises for people who've been working in this area for some time. It may have been to other people who haven't had sight of that in the past. So the headlines are over 60 different findings in there that would form the basis of the action plans. And because that self-assessment had been in place for some time and some of the work had been ongoing for some time, Julie Gibney and the team had already progressed some of those actions even before they appeared in the inspection reports. So 26 actions have now been completed. A further 27 are in progress and people are working on them, some short, medium and longer term. And 8 of those actions require resources and actions that would belong to different departments, not just necessarily Manx Care or Children and Family Services. Some of the issues just to highlight, the detail is in the report, as I've said. Children with disabilities, lack of residential placements, which has been an issue across the island for a number of years. There's always been a challenge in terms of finding the right placement for some of those young people. No advocacy service, which again has been highlighted certainly since I've been here in almost every inspection report, internal report, etc. around this. And there is some work ongoing with that. It's currently sitting with Treasury in terms of funding, but that's been highlighted again as an issue for young people. Increased need for resources not available to meet demand, so we have an increasing need and the resources we have not available to meet the demand as we speak, never mind into the future. Resources for care leavers, no legislation, so there's a few comments in there about legislation and the fact that we need to develop or improve on some of the legislation across the island. Foster carers we mentioned earlier, that's an issue. We don't have enough foster carers on the island, despite the good work that people are doing around that. I was trying to pick up on the education as well for looked after children. Still a challenge again across the island to make sure that we are providing that education for people who may not be in mainstream education. And then generally a lack of island-wide strategy for services for vulnerable children. So strategically there's some gaps in there as well. So in terms of a summary, let's not forget there's some really positive findings in there as well. So it's easy just to dwell on or focus on some of the areas of improvement. So a lot of plans are already in place, as I've said, and I think one of the comments from inspectors was that people are doing their best, but hindered by a lack of resources. I think that was a comment that stood out for me. And inspectors often commented on how honest and transparent staff and managers were during their discussions with them. So that just showed that kind of openness and willingness actually to get involved and make improvements wherever they can. So I think overall the action plan is developing well. We have an independent chair who's chairing the Service Improvement Board. It's met on one occasion already, due to meet again December the 7th. And the proposal is that we'll have some work groups underneath, some work streams underneath that board that will be working on some of these actions that still need to be improved upon. And then finally some business cases that are now in draft form. We're looking at how we might develop some of those gaps, particularly around residential respite and outreach services that we know are big gaps across the island that we need to work on. So they're in draft form as we speak, and we'll be going to the board and through a business case review group fairly soon. So good progress, lots to do, and lots of resources required to do something, particularly on the building-based stuff, which we know will be a challenge.
Thank you. Any comments or questions for David? No. Thank you very much, David.
Thank you.
Teresa, coming to you for the workforce and culture update, please.
Thank you. So this report just provides a very high-level summary of the work that's taking place within the workforce and culture team. We're hoping to sort of springboard some of this. There has been a lot of good work that's taken place. Obviously, we are currently in the process of surveying all staff across the organisation. We're obviously wanting to get the maximum amount of feedback from all of our staff as to how it feels to work for Manx Care. It will be the first time we've had a comprehensive whole organisation-wide survey. It is based on the NHS survey of the UK, and we will use that to refine our people, culture and engagement strategy. We're obviously planning and have gone live with nominations for our second Care Awards, which was highly successful in February. Starting to now look at some of the workforce planning and skills audit, which had to be delayed in years 1 and 2, just purely because we didn't have the level of data and information from which we could do that, and the thinking around what the future models of delivery looks like. We want to really progress equality, diversity and inclusion, and really make sure it feels a very inclusive environment for staff to work. Obviously, we've got the actions and the learnings from the BMA barometer and culture of care, and Dr. Hudson and I, Dr. Hudson's leading on a programme called Civility Saves Lives, which will be a symposium in November and December, taking forward that work, which absolutely links that very positive culture in working in improving the quality of care delivery. So it is a summary report, but I thought it was important just to signal the broad strands of work, and going forward I think we've committed to bring a quarterly report on the actions and deliverables of the culture and engagement strategy through to the board. But I thought this was just a helpful stock take as we given we signed off that cultural strategy last month at the board.
Thank you, Teresa. Any comments or questions? No. It's good to see the work progressing, so thank you. Okay, so we now come to the finance report. Mash.
Thank you, Chair, and good morning, everybody. The September management accounts are included within the board pack, and I'll take that as being read. As Nigel already highlighted earlier in today's meeting, the forecast has moved this month, which has resulted in an increase to the deficit that's currently being forecast for Manx Care. This is a result of 2 risks which were already highlighted in last month's management accounts, which we now have enough information in order for them to be crystallised within the forecast. This comes despite there being substantial improvements in a number of different areas across Manx Care, particularly within medicine, primary care, operations and nursing safety and governance, where the run rate in all of those individual areas has improved substantially. The movement in the forecast is a result of 2 separate issues. The first issue is relating to our tertiary costs. The movement is due to a review of recent provider activity, which shows that the existing activity levels will not reduce as much as we had previously expected. There are also inflationary pressures for the NHS tariff, as well as a transport contract that have now been included and crystallised within the forecast. Should also be noted that we have had some difficulties in obtaining timely information from some of the tertiary care providers, and this is being worked on by the tertiary team at present. The second impact or movement to the forecast relates to the CIP, and that's following a detailed review of the forecast savings that were felt could be made by the CIP. This has been adjusted, which means that the delivery of the SIP will be lower than previously forecast, and that reflects the run rates that exist within the care groups across Manx Care. So the opportunity to further reduce the forecast down any further is now limited. Moving on to the next element of the finance report. So there's a very helpful spend analysis that's been provided by Jackie in her report, and that's included and has been mentioned by Nigel already today. The key takeaways from that spend analysis and the nice graphs that are in there as well is that over the last sort of 2 years that Manx Care has been in existence, we have seen an 18% increase in costs. despite a backdrop of cumulative inflation of around 24%. So it's very clear that work has been done and has been very successful in mitigating costs across Manx Care, because the inflation that it has been subjected to during that period is quite significantly higher than the actual cost base increase during that period. During that same period, the budget has only increased by about 13%, and that's where the gap currently exists for Manx Care, between the 18% cost base increase against a budget increase of about 13%. During the last month, with it having been 6 months into the finance year, reviews were undertaken with a number of the care groups, particularly within acute care, and very happy to say there has been substantial reductions in agency and bank spend in a number of the care groups, with 2 of those care groups seeing very significant improvements when compared with this time last year. The work that's happened there should be credited to Manx Care and those care groups, because that has taken a significant amount of cost out of the base for Manx Care. Just wanted to put on record as well that there has been great input and collaboration from all of the care groups within Manx Care on their finances. There's been very real creativity and pragmatism by all of those care groups, their managers and the people that work within the care groups, to make the best of and to reprioritise the budgets that they have. This has also helped with robust financial forecasting and planning, which has improved greatly over the last 2 years. And there's been a high degree of input and investment in time from the care groups and colleagues in Manx Care to help with the financial forecasting. It's very clear to me that there's been a real improvement in financial understanding and literacy within all of those care groups, particularly compared to several years ago. And I'm very proud personally of the improvements that they have made. Moving on to the final part there of the finance report, which just relates to the funding envelope for next year. So the 24-25 funding request has been submitted to the DHSC. We are hoping to find out about the funding envelope within the next couple of weeks. I believe that that information is reasonably imminent. Upon receipt of that, we will then look to prioritise budgets for next year based on the list of 6 priorities that we used to produce that information earlier this year. I know that everybody in the board and within the exec team will take part in that exercise. So that's pretty much the update on all of the finances there from me. I'm very happy to take any questions that anyone has or any particular comment anybody has about the finances. Thank you.
Thanks, Ash. Thanks very much. Katie.
Thanks, Ash. So, a couple of comments, or one comment and a question actually. First, the comment around your the fact that you're very proud that people are getting more financially literate. I think that we heard that yesterday from Teresa when she said 4 departments have now, for the first time, managed to come in on budget, which is just brilliant. You know, I mean, that it sounds like that's a given, but it isn't. No. So yes, you're absolutely right. The financial literacy is so important. First thing. Secondly, out of cycle, we were asked to approve a high-cost patient spend, which was absolutely the right thing to do. And I did come back and ask the question about whether we always go back and seek help with that from the government. So can you just comment on high cost patients, whether we always go back and ask for additional financial help with that, or whether sometimes we just basically suck it up?
I think in terms of high cost patients, I believe there is additional funding that can be provided there from the Department of Health and Social Care. So they hold a separate reserve that can address that, but they have specific criteria around that. I haven't got the specific criteria to hand. I think there are examples of where Manx Care has absorbed higher cost patients, but I think that more relates to where it's ongoing or concurrent. So if we have, so to speak, one that is brand new and occurs in year, then I believe that it qualifies for the funding. Where it's ongoing and it relates to more than one financial year, I think there's a little more room for discussion there about whose baseline tackles that.
Okay.
Okay.
Thank you.
Thank you. Any other comments or questions? Tim?
Just to, I've got a question. So we understand the 13% and the 18% and the gap in funding, and how that's year on year, and to mix Nigel's analogies around squeezing the stone and salami slicing. I just wonder, are there any further substitutions that can be made within the SIP? Because that is quite a significant reduction. And I know we're mid-year, so anything we start now is going to have a very limited effect on the end of year. But just really assurance that while we have reduced that, we are continuing to look at whether there are substitutions, whether there are other areas we can explore and mine in terms of cost improvements.
Yes, absolutely. So that's a very good question. So the work that's done as part of the SIP programme is reviewed on a monthly basis, and I believe that new work streams build into that quite frequently. And from just knowing and working closely with the care groups, there are a number of work streams that they're looking at that aren't potentially worked up enough to include that within the forecast. So to answer your question, yes, absolutely. If that information changes or becomes more relevant and we can input that into the forecast, then we will do.
Thank you very much.
Thank you. Charlie, Marina, and then Teresa.
Thank you. Again, a quick question, if I may. I note in the report that there was we've had a payroll error, haven't we, in a couple of the divisions, here resulting in some back pay. I just wondered what the process was that uncovered that, and to receive any assurance you have that we are likely or not to see that occurring before year end in other divisions due to payroll error. I think it's just good that if we're braced and prepared, if that is an additional potential risk going forward before financial year end, or indeed just before financial year end, which just to prepare us
which we
for that if possible. Yeah. So are we satisfied that that won't or can't happen again, and to what degree is that assurance, please?
It was found, I think, due to a reconciliation of doctors' pay against job plans.
Right.
And it was discovered that a number of people hadn't moved up the pay scale for a number of years in some cases, which was kind of quite surprising that it hadn't been flagged up by the individuals. But it seemed to have arisen from an area where we've changed membership of a team who did that piece of work, and it wasn't done. And also the audit process that would have picked that up, just due to pressure work that had been dropped because it was felt to be quite low risk. We are in the process of doing an exercise to see if whether that's been replicated either across government or in any other staff groups.
Yeah, forewarned is.
Thanks, Charlie. So is that, Nigel, just to give you a bit of warning about my question, as the chair of audit, is that sufficient? Is the piece of work is that being done by the Office of HR? Are we, I suppose, if we wait for that piece of work and then perhaps make a decision as to whether that gives us the assurance that Charlie's requesting, or whether we need to ask internal audit to do anything else?
I think it's a good question, Sarah. Yeah, and obviously it's probably incumbent on me to do that, because I think what's quite interesting is that again, audit subcommittee, we work with government's internal audit. We have a programme of audit that covers a number of key subjects over the year where the internal auditors go in and give a particular subject a good kicking. That is linked to a little bit of history. It's linked to currency in terms of where on a big change management programme we would tend to ask internal audit to factor in a visit after that change management programme to ensure that what we think is happening and it's having the desired result. And then there is some capacity within that audit programme to pick off individual subjects from time to time. And this is probably one of those that we could bring up and say, when Anne had finished her internal organisation checks and reconciliations, maybe in some time we could go and get that assurance from internal audit.
Thank you. Marina and then Teresa.
Just to stay with what you're talking about, Nigel, and I'll go back to Ashley because it's in my head. The area that was picked up, one way to avoid it is to make sure that the job plans are done at the beginning of the financial year. Because if they're not done, then you're going to have to back pay people. And for years, we didn't have job plans signed off. So that's why we ended up in the position that we did. But so much work now has gone into job planning. Jackie has spoken with the MIAA. I've spoken with Dr. Endelson, who came and spoke with the doctors. The BMA has spoken to the doctors and to the clinical directors. And I hope that going forward, we will have a much more open, transparent way of job planning happening in a timely way, or else this problem will occur again. Even now, if you're signing off job plans in November, people are going to want to be back paid to April, and it's very hard to say, actually, we've got to do it from today because we haven't got money to back pay you. It makes people feel very offended.
Okay. Thank you.
That's number one. Number two, going to Ashley. Excuse my naivety here, Ashley, but it's just, there's a method to my madness. Unavoidable cost pressures is number one as priority. How do we distinguish that from enhanced service delivery and new service development if actually it's a service that the patients need and they're not getting it at the moment? If we look at it as a new service, it goes right at the bottom of the list, but it might be a service that actually patients haven't been able to access, and it is something that they should be accessing rather than something aesthetic.
Okay, so that's also a very good question. In terms of unavoidable cost pressures, we look at the cost base for each of the care groups during the previous financial year and determine what there is part of their existing run rate. Doesn't relate to anything like new service delivery. It's just what's happening on the ground and has to be addressed. Likewise, things like inflationary pressures and stuff would build into that as well. In terms of determining, whether something around enhanced service delivery, or I forget the other one you mentioned, but the other items should be included as unavoidable cost pressures. I don't believe that's for finance to determine. I think that's for the exec to determine.
Thank you.
Thank you. Teresa.
Yeah, so there is a more broader and fundamental issue which sort of probably explains why this matter did arise. So we sought to have the assurance that, particularly because it arose from a query from medical staff through the BMA, that consultants were on the right spine point, were on the right increment point, were being correctly paid in line with their job plan. And we committed to do that reconciliation which identified these anomalies. Now, this should be sort of part of our standard practice and part of our sort of monthly business due diligence to sort of check the nominal roles, check we have appropriately closed down people who've left the organisation. But fundamentally, we have an issue which means there's a lot of manual work involved in that because our financial systems and our HR systems do not talk to each other. So fundamentally, we have to do that sort of manual alignment and checks and balances. And every year we go through that process as we start the new financial year of making sure we have alignment with the PIP, the workforce system and the financial system. So we start the year as much as we can in reconciliation. But as we go through the year, there is drift. And that requires an awful lot of manual checking underneath to make sure, A, we're not paying people too much or paying people too little. And neither are good. So, I've certainly had to be involved in a number of cases where we've had to recover overpayments to staff as well as address underpayments, and neither is good. So we do have to tighten up our processes, and I would absolutely agree that given what we have found and what we continue to find and that misalignment, that we do ask audit to particularly look at this area going forward.
Sarah, if I may come back.
Ash has got
sorry, forgive me.
Sorry.
I was just going to add into that, just talking about the reconciliation that happens between payroll and the finance systems. So as part of this financial year, we've set up quarterly catch-ups with the payroll team, particularly with the head of payroll, to address a number of the ongoing issues that we've had. They've been extremely helpful in that process. They're absolutely on board of working with us as closely as possible to align all of that. The issue that they've had is that they are suffering from recruitment issues within their own kind of payroll team and stuff as well. So getting all of that work up to speed and those work streams up to speed is just taking more time than originally envisaged. But we are working on it and can hopefully provide you with more assurance around things like pay longer term.
Thank you. Nigel, and then...
Yeah, I was just going to say, Sarah, if I may, that although this is seemingly at the surface some bad news that we've discovered this, I think it's very important to pause and smell the roses. You know, my time on this board, when I first came, I was very aware that a lot of government was very siloed. And you know, those silos didn't always talk to each other. But the very fact that we've got this on the table, I think, should be celebrated because we can deal with it. And the very fact that Ashley is giving us assurance and evidence that communication is happening and that people are working collegiately across teams, I think is very good news. And I think we should celebrate that as well as deal with the issue.
Thank you. Oliver.
So it just strikes me that possibly one of the best auditors of individuals' pay is probably the individual themselves. And I wonder if this is something that's happened more than once or several times. Are the pay slips easy to understand? Do Manx Care staff have the knowledge and understanding of how much they're paid, why they're paid this much? And can they see that connection with what their job plan is? Because it might be that if that kind of literacy of or understanding of how the whole system works was improved, I suspect most people are quite keen to make sure that they are properly paid, and maybe this would be avoided in the future. But I don't know what the pay slips look like. I don't know how easy they are.
No, I think they're very clear, very detailed. I think it is about promoting that use of the self-serve. You know, it would be interesting whether we can actually audit how many people do go into PIP and look at their pay slips, update their personal information. I mean, it's a self-serve basis, and we proactively encourage that. But it would be good to see whether people never ever go and look on PIP to look at their pay slip and check it's accurate. Yeah.
I think you'd be surprised, Ollie, in that what you're referring to as a third party unwilling internal control. So it's like when you go into a shop and buy a book, the cashier rings up and you see the figure in front of you, so you know you've got the right change. It's exactly the same principle. But I think you'd be surprised as to how many people just take it as read and actually don't. Maybe that's something that we could learn.
Perhaps, Nigel, don't even take it as read. Don't even go in and read it.
Don't even go in and read it, exactly. Yeah.
Is that information available to us, Sam?
Yeah, we can do that.
Okay.
I was going to say that what's perhaps surprising in this instance is some people hadn't had an increment for several years, and you might expect that individuals would pick that up.
Yeah.
Really, it's not just about seeing your pay; is that you might expect the money in your bank account to increase, and it hasn't been picked up.
I think the way to take this forward then is perhaps for People Committee to look at. To be able to have a look at, you know, how many staff are going in and checking their pay slips. Have we got an issue? Do we need to do a piece of internal communications and engagement work around, you know, the fact that it is self-service, Teresa, that there is a responsibility on the individual as well as on the manager to ensure that, you know, that both of those things are coming together. And I think, you know, Charlie's original point about we don't want to be surprised again is a really important one. And I think that, you know, one of the conversations we've had systematically, and I know Nigel's had in a lot more detail in his committee, is around working on this no surprises basis for the financial outturn. And, you know, that's why it is so important, to Katie's point, that we are seeing greater financial engagement by non-financial managers, because that is not an easy thing to overcome in any organisation, and particularly one that's as complex as health and social care. So I think we've heard some encouraging things about the money. We've still got a big job ahead of us, and you know, I know because I've spoken to them that our staff understand that. And I think the board just needs to ensure that we continue in all of our standing committees to ask the right questions around, the controls, whether those are controls about safety and quality or controls about money. Okay, nobody notified me of any other business, and it's 7 minutes to 12, so I am in the very amazing position of giving you 37 minutes back in your life.
Wow.
So thank you all very much for your engagement today. Did we receive any questions from the public?
No, we haven't received any.
It's the first time in the history of Manx Care not to have received any questions. So I hope that isn't the way of the future, because I think it is really important that people do feel that they can ask us questions. So I hope that's an exception rather than a new way forward. And I'd encourage anybody who does want to ask the board questions to send them in. So thank you very much indeed.
Thank you.
Thank you.